Thank you very much, Dr. Juka. First of all, I'd like to say Santi sana to all our participants, and thank you for the teams from the University of Nairobi and KNH for organizing this health symposium. As we communicated to in the theme, the NCDs are the new pandemic, and we want to discuss challenges and innovations in management in the course of this week, with a focus on hematological diseases. With us, we have a panel of experts. I'll start by just giving a brief introduction before we go into the sessions themselves. We have with us Dr. Gladwell Gathecha, who is the Deputy Head at the Department of NCDs and also the lead of the Technical Working Group on hematological conditions at the Ministry. Also doubling up as the Head of Violence and Injury Prevention. She will be followed by Professor Jessie Githanga, who I'm sure we are all familiar with. She's from the Department of Human Pathology, the Unit of Hematology at the University of Nairobi. Thereafter, we'll have a session from Dr. Kibet Shikuku, also with the University of Nairobi, who will be promptly followed by Dr. Victor Kibe, who is the head of the Non-Communicable Diseases Unit at Nairobi City County. And we'll close our sessions with Eunice Owino, who is a Sickle Cell Federation Kenya worker and also one of our sickle cell warriors. Maybe so that we move in the interest of time, we shall be having 15-minute sessions, which we shall have a short Q&A before we move on to the next sessions. So kindly feel free to ask your questions in the Q&A section, and we shall take them and answer at the end. So without much ado, I'd like to just invite Dr. Gladwell Gathecha, maybe just to give you a brief background on her. I already mentioned she's the Deputy Head of the Department of Non-Communicable Diseases at the Ministry and is actually the focal person for sickle cell disease. She holds a master's degree in applied epidemiology and has a bachelor's in dental surgery. She has led several research and implementation projects, which have had major impact in creating knowledge about non-communicable diseases in Kenya. And this has led to changes in policy. Dr. Gathecha is also the National Coordinator for the National Non-Communicable Disease and Injuries Poverty Commission. Karibu sana, Dr. Gathecha. We hand over to you. Dr. Gathecha, are we able to reach you? I think we may be having a bit of a technical difficulty. Let's just take a minute to try and resolve that. Kindly be patient with us. As our technical person is resolving that issue, I would just like to reiterate, Dr. Gathecha will be taking us through policy implications and alignment for the hematological conditions. Maybe for those who joined a little bit later, Dr. Gladwell is actually the Deputy Head of the Department of Non-Communicable Diseases at the Ministry of Health, also doubling up as the Head of Violence and Injury Prevention. And she's the focal person for sickle cell disease, that technical working group. As I mentioned, I am the secretary to the same, and she'll be taking us through policy implications and alignment for hematologic conditions. Thank you, and karibu daktari.
Okay, thank you very much. So without wasting much time, I'll go straight to my presentation. And it's just thanking the organizers for this opportunity to present. This is an overview of my presentation. I'll start with the burden of sickle cell disease. And from the word-go, I'd like to point out that I'll be focusing on sickle cell disease. Well, Dr. Kibet later on will talk about hemophilia, but I'll try and tie up the policy implications for both of them. But you'll see a lot of my slides in respect to sickle cell. So we are estimating that each year, 14,000 children are born with sickle cell, and we upped this number because of looking at the average of the studies that are done in various hospitals of the number of newborns who are born with sickle cell disease, and then projecting that annual growth from the population census, and also just taking into mind the high sickle cell burden counties. And that's why we came up with that figure of at least 14,000 people and children born annually with sickle cell disease. In Kenya currently, there are 17 high burden counties, mainly distributed in the western region and the coastal region of the country. So
Dr. Gladwell, we
yes?
don't seem to be seeing your presentation.
Let me stop sharing and share again, because I was on sharing. Is it visible now?
Not yet.
Okay, then Nelson, please just share for me. I'd shared this presentation. Maybe as he continues sharing, I can pick up from where I was. So there is mainly the high chance of healthcare workers missing it out, and also the family members being thrown in a limbo for most of these hematological conditions. And that's why, as a Ministry of Health, we want to emphasize on the issue of early diagnosis and early screening. And for hemophilia disease, which I said Dr. Kibet will handle later, we have an estimated 5,000 people living with this condition, but this is likely an underestimation because we don't have accurate data. I'll now look at the status of sickle cell disease in the country. And first of all, I'll pay due diligence to Save the Children, who did an formative assessment earlier on in the year, looking at the screening and treatment areas. For the screening and diagnosis, this is some of the findings that they came up with, that there is generally lack of screening and diagnosis equipment at our public health facilities. And it's even worsened that the healthcare worker knowledge on the two procedures is wanting. And adding to the cost element, that many of these screening and diagnosis services are unaffordable. And most of the screening facilities or diagnosis, if available, are found in the private facilities, and therefore making them inaccessible to majority of the people. When it came to treatment, they found these notable gaps. And this is a formative assessment that was done mainly in Bungoma, Nairobi, and Kilifi. But again, it is representative of the country. They found that there is severe staff shortages. Thank you. You can go on. Move the slides ahead. Go on. Yeah, I was speaking to this slide. So when it came to the treatment area, they found that there was staff shortages as is experienced with other diseases. And though as a ministry, we had launched the sickle cell guidelines last year, they had not yet reached the ground, and many of the healthcare workers were not following the guidelines. We also advocate the issue of support groups, so just that the warriors are able to have psychosocial support. And they found that especially the rural areas, these support groups are not very much prevalent, but they were a bit more active in Nairobi. NHIF, looking at the financial aspects, there was a gap there in that they were not covering a lot of the medicines required for sickle cell disease. And the medications themselves, they were often out of stock in the facilities where the assessment was carried out. Next, please. Now moving on to the health policy implications. And I want you to focus on the rectangle on the middle. This is the policy objectives of the Kenya health policy. And I just want to point out that in prioritizing the issue of sickle cell disease, there are actually 3 objectives that speak on sickle cell disease, reducing the burden. And the first one is the issue of reducing the burden of NCDs. As you're all aware, sickle cell is an NCD together with hemophilia. And then there's the issue of availing essential services. That's the 5th one, as you can tell there. And then the last one is the issue of the partnerships. We cannot bring the burden of sickle cell to a minimum if we are only doing it as a Ministry of Health alone, or even as a health sector. So the Ministry of Health has prioritized the issue of strengthening collaborations to reduce the burden of sickle cell disease. And then narrowing it down to where the NCDs lie in the Ministry of Health, that is the Department of Non-Communicable Diseases. We do have a strategic plan for NCDs that is running from last year to 2026. And in the scope of these priority diseases, we did include hemophilia and other hemoglobinopathies, such as sickle cell disease. Maybe you can move on to the next slide. Yes, so I've highlighted that in our NCD strategic plan, we do have those 2 hemoglobinopathies being taken as priority diseases. Next, please. Just to further tease down the strategic plan, we are implementing the strategic plan in 5 pillars. The first one being sectoral and multi-sectoral coordination. And under this, for the hematological conditions, we have ensured that there is a coordination mechanism, which I'll speak to a bit later, in that we formed a technical working group that takes into cognizance the academia, research institutes, warriors who are people living with NCDs, and also developmental partners. Number 2 is the area of minimizing risk factors for NCDs. And under this, what speaks to sickle cell disease is that we are trying to ensure that, for example, the vaccines that should be availed to reduce severe consequences are there. Like, for example, when COVID-19 struck, we ensure that people living with sickle cell disease are one of the priority people who are considered for this vaccination. And then there's the health systems response for management of NCDs. This takes into cognizance the health systems delivery areas. For example, to improve supply chain, to improve the health workforce, and also to improve infrastructure, and also ensure that management and diagnosis is available at primary healthcare level, and also it's entrenched within universal health coverage. Fourthly, there is the issue of advocacy, communication, and social mobilization. And here we rely a lot on our partners outside health. Our warriors also play a big role in here, just trying to especially in our setting where health is devolved, make sure that the counties are really prioritizing sickle cell disease. And lastly, it's the area of surveillance, monitoring, evaluation. So we've been trying to input systems for sickle cell disease and hemophilia. Right now, we can't really tell, like, for example, what is the workload in our hospitals as far as seeing patients with these two conditions are concerned, because at the moment for all the anemias are tied in together, but that is something that we are working on to be able to show that, number one, what is the true magnitude of these diseases in the country, and what is the monthly and yearly or quarterly workload for our health facilities. And eventually that will help us ask some even more deeper issues like the economic burden of these diseases. Next slide, please. Now
recording in progress.
We are
recording in progress.
Let me. We are now joining the global world in trying to advocate for screening for sickle cell disease at infancy, and we've made much progress in this phase. We are just completed, and our ministry has signed the policy on infant screening for sickle cell, and the guidelines will be disseminated soon. So we want to target the neonates and infants up to 1 year of age, and we'll be using the immunization sites as our target area, so that, like, the first immunization will happen from birth, and then we target, and those we are not able to get, maybe we aim at the 6 weeks immunization. We want all level of hospitals provide these facilities of screening, and we'll be doing it because it's a screening test. We'll just do rapid diagnosis tests for those that are registered in Kenya, and we'll be collecting the sample from the heel prick. And then those who are found to be positive at this screening stage will be taken for further test for diagnosis using HB electrophoresis. Next, please. Next. So the essence of screening is really to get these conditions early enough, and the counseling that will happen thereafter and the linkage to care is what is the goal or ultimate goal for the screening. So we'll have to ensure that there is proper linkage to care, in that we are not even just screening for the sake, but we'll have to ensure that those who are screened and found positive and eventually diagnosed are linked to care, so that we reduce the outcomes, the severe outcomes earlier. And that means that our whole stretch of the health systems will have to be improved, and that is something we are working on. And those found to be with the trait, sickle cell trait, will be cancelled and then advised to come later on during adolescence for counseling. Next. Next, please. On leadership and governance, I alluded to this, that we do have a hematological diseases technical working group that makes sure that now issues of hematological conditions are not just a purview of the Ministry of Health, and the leadership comes from the Ministry of Health, and also the second co-chair is outside Ministry of Health, that's Dr. Kibet, so that at least there's a bit of accountability for anything that we propose, and we ensure that things are done to fruition. At the moment, the scope of the TWG is non-malignant blood disorders and hemophilia and other hematological conditions. Next, please. When it comes to health workforce, very critical component which can make programs fail. We do have a training curriculum under development, targeting staff at primary healthcare level. We are now insisting of a lot of services being held at primary healthcare level, and we also do have continuous medical education with our counties. Next. This is the sickle cell guidelines for management we launched last year, so that we ensure that there is standardized and quality care that is being given in our health facilities, and it details what services should be available at each level, and also details the essential medicines and essential equipment that should be available at each level. Next. For service delivery, there's a lot of talk towards integration, especially for programs that are not well resourced. We do realize that the importance of that, and we as a program are trying to make use of other well-resourced programs or other closely related programs, such as maternal health, disease surveillance, child health, to ensure that at least healthcare workers are either trained or whatever resources, be it even in the area of health promotion or health information, that we make use of the integration process to ensure that the agenda is driven further. And then we also very much emphasize the role of patient support group. And we have come up with a guidance to guide support groups on how they should be formed and maintained, so that they are providing this social cycle support, and they're also providing much more like encouraging and their adherence to treatment. So that is one of the areas we are really laying much emphasis on. Next. Next, please. Health information, an area where there's a bit of challenge because, as I explained before, our routine data does not capture any hematological disorder in distinction, but we are looking towards changing that. Research currently is mainly performed by academia and institutions such as Cambridge, but we do try and integrate sickle cell disease in other indicators, such as national surveys, like the adolescent health survey looked at adolescents with sickle cell disease or even knowledge of sickle cell disease. And any national M&E activity, we also include sickle cell disease. Next. For health products and technology, an area that I admit that is the main challenge for our sickle cell warriors out there, but we have added hydroxyurea to the Kenya Essential Medicine list. At least now it's available as a medicine for treatment of sickle cell disease. And we are sensitizing our counties, our health facilities to ensure that they order drugs for management of sickle cell disease, so that at least when patients visit these facilities, there's something they can come out with. Next. Health financing and UHC. As you realize, all these I've mentioned above is not possible unless we have a strong financial mechanism. So despite the heavy burden of NCDs, currently we are seeing that at least 41% of the deaths are due to NCD. The financing is only a meager 11%, but we continue to make a case for more funding, and there is indeed been more improvement. And currently in the country, a lot of the funding towards NCDs through the government, but a lot of partners now are coming on board, and the situation is most likely to change. We've already seen this changing with the National Health Insurance Fund. There is a move towards increasing the package for sickle cell disease, and I'm sure with continued advocacy, the package for treatment will increase. Next. Health promotion, a lot of myths and misconceptions out there regarding sickle cell, but we are trying to curb that. For example, we do create community awareness. We do have commemoration of World Sickle Cell Day and IAC material. The picture on your left just shows one of the IAC materials. And also to really bring the face and of sickle cell, we do have 2 sickle cell champions, and they are supposed to advocate and champion for the sickle cell cause, and both locally and internationally. And they have been doing a good job so far. Next. Partnerships and collaboration. As I said, it's not a Ministry of Health affair only. I want to highlight 2 areas where we are going to move forward with sickle cell disease. This first one is a collaboration between Ministry of Health and Novartis that will strengthen health systems for sickle cell in 18 countries. And then other one is strengthening the secondary level care for sickle cell. in 2 counties, and this is by NCD Alliance and Partners in Health. So they'll really work at that referral, that level 4 hospitals to ensure that the healthcare workers there are knowledgeable and there is the right equipment for management and diagnosis and management of sickle cell disease. Next. So these are some of the challenges. I've been mentioning them as I go along. The issue of drugs, the lab capacity, and also the supportive treatment, the limited personnel knowledge, and then also the big health information system. I think that should be it. Please, next. Just in a way of way forward, I can't just leave it with the challenges. So this is what we've planned as a ministry. We are rolling out the policy on infant screening in a phased approach. And then the CHVs, and as I mentioned earlier, the primary healthcare being an important component, we will be training the CHVs on hematological conditions in order for them just mainly to identify and refer. Then we'll also have a development of disease-specific strategic plan, with the first one being on hemophilia. And then we'll have a continuous advocacy at county level. And then we'll also establish data systems for hematological diseases. Next. Thank you very much. I know my presentation has been plugged with a lot of technology hitches, but thank you for your attention, and back to you, Dr. Mutiso. Thank you.
Thank you very much, Dr. Gadecha. We have been able to get the message loud and clear as regards the policy and the directions from the ministry and with the stakeholders. We had a few technological challenges, but we have been able to overcome. I think the message is well delivered, and we appreciate that very concise delivery. Perhaps we shall move to the next presentation, and thereafter we shall answer the questions in the Q&A section of the chat. I'd like to introduce someone who is well known to us and very dear, Professor Jessie Githanga, who is an associate professor at the Department of Human Pathology at the University of Nairobi, where aside from teaching, she also provides clinical services in the hematology and pediatric oncology departments. She's also a member of the Kenya Society of Hematology and Oncology and the Kenya Association of Clinical Pathologists, as well as a board member of the Kenya Network of Cancer Organizations and the Kenya Childhood Cancer Trust. I think Professor Githanga, you have the floor. Maybe by way of introduction, as we wait for her to share her screen, she will be taking us through the challenges in the diagnosis of hematological malignancies. Karibu, Prof.
Okay. Allow me to share. Join as a panelist. Unmute. Okay. All right. You can see my screen. Let me put it on slideshow.
Yes, we can see a screen.
Oh,
Proceed.
good. All right. Okay. Thank you very much. Sorry for that short delay as I was trying to share. I'm very honored to be here in this conference, and I thank the organizers for inviting me to talk about the challenges in the diagnosis of hematological malignancies to this good audience. I will first ask you to lend me your ears as I go through my talk. I'll go through an introduction of the hematologic malignancies, and then we shall say that all that glitters is not gold, and I'll tell you why. And then I will go through quickly some key diagnostic challenges that we face. And like Dr. Gadesha, it's no good just giving you all the challenges without suggesting a way forward. So hematologic malignancies are about 10% of the overall cancer burden in Africa. And there's no reason to think that Kenya will be any different from the rest of the African countries. So we can expect that 10% of all the cancers will represent hematologic malignancies. So this is a significant burden. The treatment of these hematologic malignancies in resource-rich settings has seen unprecedented rates of long-term survival and improved control of the disease. For example, previously fatal diseases like chronic myeloid leukemia are now curable with a magic bullet tablet. Some of you may have heard of the medication that we give for chronic myeloid leukemia, imatinib, which has provided long-term cures for patients. And the most common childhood cancer, which is acute lymphoblastic leukemia, that's one of the types of blood cancers, is potentially curable in more than 80% of cases with the proper treatment. And recently, there is a new approach to having personalized cancer therapy, which acts directly on a patient's immune system and destroys the cancer cells. And this is providing very exciting new avenues for the treatment of many cancers. However, unfortunately, the mechanisms for quality diagnosis and management of these conditions remain quite inadequate in Kenya, like in very many low resource poor settings. Now, which are these hematopoietic malignancies or malignancies of the blood and blood forming organs? We have a large group known as the lymphomas, and this is where the malignant blood cells form a swelling, which is usually affecting the lymph nodes. Then we have the leukemias. This is the blood cancer. So the malignant cells are in the bone marrow where blood cells are produced, and also often found also in the blood, peripheral blood, with the other blood cells. Then we have the myeloproliferative neoplasms, quite a tongue twister, but this just refers to other malignancies that affect the bone marrow. We have certain conditions such as the myelodysplastic syndrome, where the cells of the bone marrow are unable, they are abnormal, they're unable to produce normal blood cells. And very often, this type of malignancy can change into another malignancy like an acute leukemia. Then we have the plasma cell neoplasms. Plasma cells in our body normally produce antibodies. They are very useful for fighting infection. However, those cells can also become malignant. And then we have a host of others, which I'm not going to go into much detail about, but just so that you know that there are very many others like histiocytic, mast cells, dendritic cells, etc. So I've just highlighted on the 4 more commoner ones, but remember there are quite a few others. All that glitters is not gold. Why do I say this? Very often when we go to a cancer center, we will be told, yes, we have an MRI machine. Yes, we have the latest laboratory equipment. Yes, we have the latest, the personnel, the well-trained personnel. However, there are key prerequisites for best treatment outcomes. These are what I call the 3 A's. One is awareness about these malignancies by patients and by healthcare workers. Because if there's lack of that awareness, this patient will never end up in that glitzy cancer center. Secondly, access to diagnostic facilities. We do know that in Kenya, the distribution of the diagnostic facilities is very unequal. The majority are found in Nairobi and possibly a few other major urban areas. In the rural, there are hardly any, and even the access for the typical person living in the rural setting to go to get a quality diagnosis is literally, like pulling a tooth from a person. And then we say accurate diagnosis. And I'm emphasizing on accurate diagnosis. This has to be a quality diagnosis, a diagnosis that is the same whether I did it here in Kenya or I did it in UK or the US, wherever it is, that diagnosis holds. This is the starting point for management. If that diagnosis is not complete, for example, it's not enough to just be told you have leukemia, because the treatment you get will not be good enough. You must be told that you have acute lymphoblastic leukemia, and you must be told it is of a certain characteristic which needs a lot of testing in order for you to get the best treatment. That's why I say all that glitters is not gold. These things that we often forget must be present. Let me touch on low awareness. It is not only patients who have a low awareness of the disease. Very often, the healthcare worker that they find at the health facility may not imagine that the patient has a neoplastic or a cancerous hematological disorder. This is because many signs and symptoms of these diseases are non-specific. They may mimic commoner diseases. For example, leukemia, especially acute leukemia, may mimic malaria, it may mimic typhoid, it may mimic TB, or lymphoma can also mimic TB, or other infections. And so you'll find the patient has been going today, he's told it's malaria, then tomorrow he's told it's typhoid. The next time they say, yes, we think it is TB. And by the time they present, it is so late that it is very hard even to offer them the chances of a cure. Most patients also end up being transfused because a lot of these hematologic malignancies affect the bone marrow where our red blood cells are formed. And therefore, these patients will have anemia. What happens is that often they will be given blood, they look better immediately, they're told, okay, you're well, now go home. But they're very soon back at the hospital again with lack of blood. Therefore, one golden rule that I would like everybody to take home is that if you give or you get a blood transfusion and you don't have the accurate diagnosis of why you needed blood in the first place, this is the same as somebody coming with a wound that is full of pus and everything, and I just take a large plaster and I bandicare it on that wound. You know that that plaster is just hiding what's happening, and the patient will come back worse. So we must have an idea that if this patient keeps coming back and forth, have that idea in the back of your mind. Could this be cancer? Could this be a hematological malignancy? Access to diagnostic facilities. Accurate diagnosis requires quite sophisticated testing. We do have currently national guidelines for patient and specimen referrals. The ministry has put this up. I would implore everybody to familiarize yourself with them, especially if you're looking after patients, so that we know we are referring the patient or the specimen to where it's supposed to be referred to. All cancer centers, and we know we are always seeing everywhere you go. I remember passing a petrol station in Kenol on my way to Moranga. There was a petrol station, and next to it was this building, and it was written Cancer Center. We know every cancer center ought to have basic minimum testing facilities. And we do have guidelines published by the National Cancer Institute on the management or on the establishment of these cancer management centers in Kenya. These guidelines ought to be implemented so that we stop having places where patients get fooled, they're getting into a cancer center, and they discover there's nothing there. And so we must avoid referrals to centers that do not have adequate facilities. So if a patient is seen, for example, at level 1, don't just send them to level 2 because that's the next level, and level 2 to level 3. You ought to be aware, if you think this is cancer, they ought to go to a level 4 or 5 facility that has the ability to make the diagnosis. Then our next hurdle is accurate diagnosis. Now, please do not think of diagnosis just of machines and specialists there doing the tests on these machines. The very first and important step is this clinical presentation of the patient. This is done through a detailed history and physical examination. Then now we come to initial basic tests, such as blood counts, blood film, biochemical tests. These biochemical tests might be looking at calcium in the blood or looking at certain enzymes such as LDH in the blood, etc. Then we have specialized tests which ought to provide the specific diagnosis. And I will let you know shortly which kind of testings these are. But if we put in our mind that these 3 levels ought to be present when we are making the diagnosis of our hematologic malignancy. Now, if we are thinking about the clinical presentation, and as I said, because of this lack of awareness, we need to know how might this patient present. Now, for the leukemias and the myeloproliferative neoplasms, they will present with some systemic features. Systemic features are very non-specific, things like weight loss, fever, and frequent infections. This can mimic almost any kind of chronic disorder. So you can see, again, it is already non-specific. They may have lymph node swelling, which can be in the neck, in the armpits, in the axilla, the groin, various places. The lymph nodes may be small, sometimes they can be quite large and quite prominent. Their spleen, which is found in the upper left part of the abdomen, may be enlarged. And indeed, in some of the conditions like chronic myeloid leukemia, you can get a very large spleen. The patient themselves will tell you, there is a hard stone or something very hard in my abdomen that feels like it's dragging me down. Their skin is another area where they may present with symptoms. Besides having sweating, especially night sweats, and again, you know, night sweats can be found in common disease, in more commoner diseases like tuberculosis. They will also present with easy bleeding, which presents under the skin, where you can see red swelling, red discoloration because of bleeding under the skin, or easy bruising. This is because they lack platelets, which are part of the blood that are important for coagulation. The liver may be enlarged. Bones and joints, very often they will come with tenderness in the bones and joints. Sometimes because of this, patients have been misdiagnosed as having sickle cell disease or rheumatoid arthritis or even rheumatic fever, which are a bit more commoner. They may have weakness. They're unable to perform what they usually do. They're short of breath. And this is because of the lack of blood, sufficient red blood cells or anemia, so that they are very weak. And then they will have loss of appetite, fatigue, and that tiredness all the time. So these are some of the presenting features. And as you can see, looking at them, this do not tell you that this patient has leukemia or a myeloproliferative neoplasm. This can be found in other diseases like typhoid, malaria, or even tuberculosis. So you have to be very, very careful that if a patient comes twice with malaria and you don't find parasites in the blood, you have to be very careful and maybe refer them to a specialist or somebody or somewhere where they can have careful investigations done. The lymphoma, they may present with psychological features that lack of appetite, fatigue. Lymph nodes, these can get to be very large in various areas in the body. And this pink, orange little nodes you can see, any one of those areas may swell in a lymphoma. If the chest is affected, they will be having shortness of breath and cough. Again, many misdiagnosed as either lung cancer or tuberculosis. The liver again can be enlarged. Kidneys may fail. Bone and joints may have pain and tenderness. Weight loss, loss of appetite, fever and night sweats. They may have muscular weakness, and the bone itself may be involved, and they may even come with a fracture. So you can see again these very sort of non-specific features that may be present. In multiple myeloma, bone pain is very prominent and they're very tender. They may not even be able to walk and may have to be even confined to a wheelchair because of these pains. The fatigue and weakness, again, loss of appetite, weight loss, constipation, fogginess. This diagram here shows fractures. Their bones get very weak, moth-eaten sort of appearance, and they fracture very easily. Again, because the plasma cell is very important in preventing infections, and the plasma cell is now malignant, they come with frequent infections and fever. Shortness of breath, frequent urination, because the kidneys are affected, and because of this, they also have extreme thirst. So just by knowing some of those signs and symptoms, finding a patient and looking for these signs and symptoms in a patient who seems to be coming back more than once for the same thing and not seeming to get better should lead you to be highly suspicious of a hematological neoplasm. So what are the diagnostic tests? I alluded to this in the beginning, but now more, especially for those people in the laboratory personnel, those doctors who will be asking for the test, these are the tests that you will need. Initial tests. Here, I will highlight the peripheral blood smear, the peripheral blood film. It is very shameful, and I'm sorry to say this, in so many laboratories, we never get peripheral blood film reports. And this is a basic test. And any center that is dealing in cancer that is unable to perform a peripheral blood film is an insufficient center, to say the least. There are other biochemical tests. We should be able to look for infections through doing microbiological tests. So those initial and supportive or ancillary tests are critical. Bone marrow examination. I feel so sad when I see patients referred from all over the country going back and forth to have a bone marrow examination. This exam should be readily available, even if the results cannot be read there. The test should be able to be done close to where the patient is. And this is important. Histology, which is invaluable for lymphoma. This is where the tissue is taken and this tissue is looked at. It is essential that this is done. And then we have the special tests. And these are not tests that I'm saying can be done or not done. These are tests that we insist have to be done. If we want to reach those cure rates like those of the high resource-rich countries, we must be able to do these specialized tests like flow cytometry, immunohistochemistry, cytogenetics, and other molecular tests. And for lymphomas, the various imaging, CT scans, MRI, and PET scans must also be done. So you can see there are quite a lot of sophisticated testing that needs to be there. So very quickly, the challenges, I've alluded to some of them. Diagnostic hematopathology remains limited in Kenya. Things like flow cytometry, molecular tests. There are very few public hospitals that you'll be able to find these tests. We often have to tell people to pay from their own pockets to send all over to other places. Pathologists and hematologists are too few at the national level. And again, the trainees for these are still very few. And you will find they are concentrated in Nairobi and a few urban centers, and many other county centers do not have pathologists or hematologists. Highly variable equipment and personnel. You may have equipment that is not calibrated, not standardized. Personnel, you need laboratory technologists. The training must be optimal so that they're able to do the job. Many of them should be able to read peripheral blood films. We find this does not occur. Overuse of fine needle aspiration. This is when you use a needle to take a specimen from a tumor. There's overuse of that and not enough histology being done. Deficiency of those simple basic tests, as I said. Turnaround times, you can have patients sitting in the ward waiting for 2 weeks for bone marrow reports to come, 2 weeks for histology reports to come back. That is sad. And variable quality of those reports and limited availability of the specialized testing. It's not enough to tell you about those challenges, as woeful as they are. What do we need to do? We know, and we have seen in resource-limited settings like Kenya, despite those obstacles, hematologic malignancies can be effectively diagnosed, treated, and cured. We need to create awareness and early detection, because when these patients come early, their chances of cure are much higher. Therefore, we need a lot of education surrounding the condition. Knowledge and use of current guidelines on specimen referrals and testing. Those guidelines are there, let us use them. We need interventions to address diagnostic testing deficiencies. Dr. Gladwell told us about the deficiencies they have in sickle cell anemia. Those are the same ones we see in the hematologic cancers. Equity, equity, equity. Somebody in Garissa, Magadi, Kilifi, Migori needs the same access as somebody in Nairobi. In conclusion, I have told you what I came to tell you. I've told you the diagnosis of hematologic malignancies starts with awareness. Access to facilities with quality testing resources is a significant challenge, and we need to work on that. Programs for awareness creation and education are therefore very important, and we need to promote equity in access to quality diagnostic facilities. I'd like to thank you very much for giving me your ears and listening to me. And I hope that I have passed on a message. I thank you, the organizers, again for inviting me. Thank you.
Thank you very much, Prof. We have really taken in those key messages in that presentation, and we are grateful that you have really kept within the time limits. Without too much ado, I will urge our participants to put their questions into the question and answer box. We shall answer them as we go along. Let me invite Dr. Kibet Shikuku. He is a lecturer at the University of Nairobi and a specialist. Dr. Shikuku, kindly take the floor, and you have 15 minutes.
Yeah, so thank you, Dr. Mutiso. Please confirm if the slides are moving. I just need to be comfortable. Are they moving?
They are visible. Thank you.
Are they moving?
Yes, they are.
Oh, thank you so much. So let me also take this time to thank the organizers of this symposium for allowing me to come and share some activities we've been engaging in for diseases that potentially have been thought to be less common, yet they are devastating Kenyans. And this basically is on hemophilia as a disease. And the discussion for today is towards prioritization of hematological conditions, looking at the hemophilia as a disorder, as a bleeding disorder. Having said that, then, as we all might be aware in Kenya, access to quality care is a basic right need, and the Constitution spells out this quite clearly, with a view of providing the highest attainable standard of health, with the right, again, to healthcare services. And so the state puts a lot of emphasis on this particular design to ensure that minorities and marginalized groups, I guess including hemophiliacs, have reasonable access to healthcare services, and more so infrastructure. It is actually on this basis that Kenya Hemophilia Association, which is purely a voluntary program, got registered some years back by some of our senior colleagues in the 1979. By Professors Mwanda, Prof. Kitonyi, Prof. Asili, I guess Prof. Mwanda and Professor Gidanga and the rest of the team that may have been working with the program, ensured that this particular association came into existence. And the mission really of this particular association has been to work together with other stakeholders for the social good and greater benefit of all people living with hemophilia and other bleeding disorders in Kenya. We felt that this was important, and I think from what Prof. Gidanga just mentioned a few minutes ago, access, trying to avoid disparities seem to be the key, message to all of us, that we try as much as possible to give priority to what actually sometimes looks like, it's actually meant for the few. And so, we decided to focus on hemophilia and other bleeding disorders. And this particular condition, as Dr. Gadesha may have mentioned, may be having at least about 5,000 or so patients. But right now in our database, we have about 800 patients, slightly above 800. And basically what Kenya Hemophilia Association and other stakeholders did some years back in 2014 was to try and strengthen the association's structures and leadership. And the intention here really was to try and see whether by having a slightly more revamped leadership, newer blood, trying to get more focused leadership would make change. And so a series of activities that included advocacy, including approaching the Ministry of Health, came into play. And I think for the last several years, we will be sharing some of the successes that we've achieved as an association. And for patients that suffer from this particular disease, we would easily say that there have been a lot of achievements possibly made. But just looking forward, because this is a disease that sometimes majority of us may have just heard about, some may not even have seen the kind of patients afflicted or suffering from this particular disease. We opted to work closely with the other disease entities. And I think you'll be hearing the program talking about sickle cell as well as hemophilia working together closely. And I'll explain a little later why this was the case. From 2014, the program has managed to at least establish 12 treatment facilities, 2 of which are comprehensive, and 10 can at least be able to provide care to patients, in different regions of the country. And so with a rejuvenated leadership or new leadership, a 5-year strategic plan with various activities was designed. And as I did mention, part of these activities included advocacy. And then, of course, as I did mention, we also opted a year or so ago to try and work closely with the sickle cell and other hematological disorders, because we noted that when we capacity build, clinicians in various counties, we ended up having people just sitting in offices waiting for patients that were relatively few. And so for us to sustain the services, it was easier to capacity build more than one hematological condition, and sickle cell happens to be quite common in our setup. It can be treated by the same clinicians, and patients can benefit from capacity built clinicians in the same, facility. And so sustaining services became much, much more easier. While one condition is associated with the bleeding, the other one has complications that may include occlusion, direct reversals in terms of presentation, one from the other. But I think it suffices for me to mention that once you capacity, you develop a clinician to manage both diseases, it was much easier actually to sustain this particular program. And so the 5-year strategic plan also gave us a very quick, orientation on which areas to focus on, including what financial implications we're getting into. And I'll tell you very quickly that the strategic plan was easier for us to share and even sell to the Ministry of Health, share with other stakeholders, for us to be able then to get support to manage this particular condition. We also are able to identify various roles for various stakeholders, including what the role of the Ministry of Health would be. And we all know that patients belong to the Ministry of Health, or rather the patients belong to the Kenyan government. So you can't actually execute and implement a program without engaging the Ministry of Health. And I think that has been a key achievement. And I can only applaud the ministry for facilitating some of the activities and some of the achievements that have been experienced through Kenya Hemophilia Association. And so for us to be able to provide and work closely with the different stakeholders, what was important was for us to look at the structure of the association. And we ended up with a tripod model where a clinician, a patient, and a parent would work together. I'll tell you, ladies and gentlemen, that as a country, we are so used to distinguishing and excluding some of the clients that we see by, looking like, there are 2 different categories or different groups. But we decided to demystify that by making sure that the clinician, the patient, and the parent have a conversation. All of us should be able to converse together. All of us should have different roles and responsibilities for us to be able to achieve our outcomes. So the association adopted a model that allowed all the groups to participate and get involved in care. And I think that has given each group very specific aspects and responsibilities, to the extent that it is easier for the clinician then to provide care, while the patients and the parents, could drive other agenda items of the association. And from a structural perspective, it was again quite much easier to have an executive committee supported through a board. And apparently, even when it came to identifying the chairman of the board, we just needed to identify someone that didn't have to necessarily be a clinician, but someone who has interest to support the interests of the association. And we had the privilege of getting one professor who is actually an environmentalist chairing the association, and we've had a lot of achievements. And part of the activities that actually this particular structure and organization has had to do is to develop different committees. One of the committees is an advocacy technical working group that is driven by parents and patients. And this particular committee has managed to assist the clinicians with the resource mobilization, basically driving the advocacy agenda and awareness creation. And one thing that I would easily say has assisted this disease entity to progress is that each of the groups are able to talk about the disease based on their specialties and based on their awareness about the disease. The clinicians would talk about the disease as clinicians. The patients would describe their diseases, describe their feelings, while the caretakers, who are the parents, would also describe what it means to live with a hemophilic. And so it is much, much easier for each of the groups to adjudicate what the disease really is all about from their respective positions. The other thing that the structure managed to do was to create a medical advisory committee. And I think this committee has driven a series of activities, one of which is to just determine the kind of treatment products that we could be able to use as a country, determine the distribution of these particular products to different facilities. And we have a whole subcommittee that actually looks at the utility of the products. So the committee is able to design a criteria that could be used to move product A to product A from facility A to facility B, redistribute certain products from different facilities depending on the expiration dates. And so it has been so easy to utilize products that we have. The other thing that the Medical Advisory Committee has managed to do is to identify the needs of the patients, including physiotherapy, laboratory diagnostics, and I think this has been a key discussion item, again, even from the previous presenter, trying to capacity build facilities to be able to diagnose patients appropriately. We know that some counties, for example, are not even running simple coagulation screens for patients going for surgical procedures. And so as the program advances, it is services, laboratory services, the facilities that we are capacity building also benefit, and other patients are able to benefit from the laboratory capacity that we develop. And that by extension then, opens up and improves the quality of care that is given to patients. Of course, data and research has been key. And I'll tell you, ladies and gentlemen, that through the program, we've managed to pull some level of data that is now being shared by the Ministry of Health, even in terms of decision making. We have managed to develop various research programs, including students actually participating on hemophilia and other bleeding disorder research programs. And so this enables us to understand the disease more, understand what actually is happening, the dynamics around the disease, including some of the complications associated with the disease. And the final activity that the Medical Advisory Committee does is trainings. There's a whole training component supported by the Medical Advisory Committee. And actually the needs of the trainings are determined by the Medical Advisory Committee. I think this has also enabled the committee to have a huge impact when it comes to training. The advisory committee has also managed to establish which centers can provide training. And so this helps us in planning. Finally, we have an executive committee that looks at various aspects and informs the board. Having said that then, the other thing that has been so important is that there are various responsibilities and activities that each of the groups have been managing. The association, through its leadership, is able to coordinate and implement, including accounting for all the resources that it receives. As one of the listeners may have put in the chat box, the product source. We know that hemophilia and other bleeding disorders benefit heavily from treatment products coming from the World Federation of Hemophilia. This is a world body that actually looks for the products, determines what products should go to which country, including determining the quantities that actually go to the various respective countries. And through our strategic plan, we were able to actually determine the levels of products that we could be able to request. And I think it just suffices for me to mention that the products we are getting is able to cover at least 30% in terms of factor concentrate infusion to patients. Besides that, this same body has also helped us in managing trainings, supporting some aspects of advocacy and diagnosis. And then the other thing that we've managed to do with other stakeholders is to develop capacity in various institutions. One of the areas that we've actually managed to do is to develop or renovate infrastructure, open clinics in some counties, and that is what has led us to have at least 12 treatment centers in the whole country, purchase equipment for testing, and then more so try and include sickle cell and other diseases into the program. One other thing that we have attempted to do as a program is to try and mentor other colleagues in the region. And so Kenya Hemophilia Association, through the Ministry of Health and other stakeholders, is supporting Tanzania, and we plan to escalate this to other countries so that then we try to standardize care, not just in Kenya, but also try to standardize care in the region. The other thing that we have tried to do through other companies like Roche is to assist patients, or rather screen patients that complicate. So patients with the hemophilia and other bleeding disorders, on exposure to products, sometimes they develop antibodies towards those products. And those antibodies are described as inhibitors. And so, while we are managing these patients, sometimes we have to screen them to try and see whether they have developed antibodies or not. And through Roche and other stakeholders, we've actually created an inhibitor screening program that is currently running. And we plan to do this for the next 2 years. And besides that, of course, try to create more awareness as we support the registry. More so, the association has attempted to work with the different regulatory bodies, and we've also worked with the Kenya Medical Laboratory Technicians and Technologists Board in upgrading a certificate course so that then we can use hemophilia and other bleeding disorder training, online training program to upgrade our laboratory technologies. And this has really helped us in capacity building and sensitizing the laboratory technologies on this particular condition and which tests would assist us in diagnosing these patients. With this, we can be able also to support other patients that may benefit from coagulation screening. And so patients going for surgical procedures are able to benefit from this capacity building. We've also worked with the Pharmacy and Poisons Board in terms of identifying products that can be registered and cleared so that then, this regulator can be able to assist us to clear products that come into the country and also check on the quality of the standards that come in country. And I think when we start working with the different regulators, we are able to, to provide a much more improved and quality care to our patients. I think it will be incomplete for me to leave out the Ministry of Health, Treasury, and other government entities, including the counties, for tax waivers that they have actually provided to this particular program. And, through the county first ladies, we've managed to capacity build some counties because the county first ladies have been our advocates at the county level. We work with them very closely. They are able to advise us on what to do. They can identify the needs at the county level, and we can be able to work very closely with them in providing care to patients within their particular counties. And then, of course, we've been working with the teaching and referral hospitals, Kenyatta National Hospital and Moi Teaching and Referral hospitals are, among the few hospitals that are able to provide training to patients, to clinicians that would like to train, that would like to provide care to patients suffering from hemophilia and other bleeding disorders. And then more so, University of Nairobi has now taken hemophilia and other bleeding disorders as one of those outreach programs provided, to Kenyan citizens. And then, of course, we also work very closely with individual donors. We have Kenyans who are willing to donate and support the program. We have an education program for hemophiliacs, and we now have our first student at the university, doing medicine. So, by prioritizing on different areas, we are actually able to support Kenyans and also assist those who might be needy to, meet their dreams. And I think out of this, just as I try to very quickly try to wind up, we've managed to at least get products of up to 800 million brought in country. More than 200 million looked for to support infrastructure and capacity building. We've managed to develop treatment guidelines. We also have a national technical working group that is supported by the Ministry of Health, and I think Dr. Kathesha mentioned this. We have a national registry that is being linked and synchronized with the ministry's database. And then besides that, we managed to also petition Parliament so that we could be able to create a budget, not just for hemophilia and other bleeding disorders, but we also created a budget for sickle cell as a disease in this country. Other benefits that this restructuring and prioritization has managed to do to the treaters is that more clinicians now have been trained and are participating in patient care. There's a lot of confidence in patient management from the clinicians. Nobody now turns a patient away because they don't know what to do. At least as a clinician, you have the latitude to at least support a patient confidently. We've also increased interest in research on bleeding disorders and increased treatment facilities, as I did mention. For the patients, now we have a very structured process because patients can visit clinics that belong to them. They can associate with those clinics. They are not being tossed up and about when they get to hospitals. We have very structured care programs in the hospital as well, including physiotherapy. And we are able to benchmark, with other disease entities. And we think this has helped very greatly to improve the psychosocial aspects. Children can go to school comfortably. They can be managed wherever they are. People can go to colleges. We can give them drugs to take wherever they are going. If they're traveling, we can actually take care of their medical requirements. And that helps a country to grow. The other thing is now we have international and national celebration events that are being championed through the program. To parents, of course, there is mental stability and assurance to life, and then involvement in income-generating activities that would have otherwise been affected because they would be busy taking care of their children and taking them to school. By the way, for your information, a child who is a hemophilic is, literally just incapacitates everyone, because if they try making any movements and they get hurt, they'll start bleeding. And so parents are forced to keep watching over them all the time, or they have to keep taking them to hospital all the time. So initiating this program and supporting patients and parents helps them to at least have time to look for other resources. To our stakeholders, we now have outreach programs. The county leadership is able to identify health needs, and we're able to provide those interventions that may be necessary. We've also managed to improve collaborations for factor concentrates, and we pray that the Kenyan government will be able to start buying these particular factors now, because we have given them a budget, and this budget will be scaled at different phases. And of course, we have within Parliament a bill for people with the disabilities and people with the bleeding disorders being considered. And as I did mention, we are able to work now very closely with the county first ladies. In terms of infrastructure, I'll not repeat this. We are planning to reach at least 47 counties in Kenya. And we hope that we will be able to reach every client, even as we move along, and improve diagnostics in all the areas that we go to. More so, we will continue capacity building healthcare providers in all these areas so that then care can be appropriately provided. I think other achievements that we've had as a program is providing safe circumcision. Remember, this disease is associated with the bleeding, and so surgeons have suffered immensely when they touch these patients without any level of preparation. And with what we've actually started a safe circumcision program, we've managed to at least circumcise more than 150 Kenyans, especially in the last 1 year. We've trained more than 10 surgeons from different counties, including colleagues from Tanzania. We've also managed to train some registrars at Kenyatta National Hospital, and I guess by extension, colleagues in Eldoret. And then, of course, we managed to get a donation of about 50 million to support the circumcision program as a country. We've also managed to donate various testing equipment, some that are fully automated. We've actually done almost 5, fully automated equipments to counties. We have, submitted and delivered physiotherapy equipments worth 11 million to different counties, Kenyatta and Moi Teaching Referral being the largest beneficiaries. We've also managed to sponsor the first induction meeting by the new first county ladies, so that we can try to induct them to the program and see how they can support us. This is a summary slide that just shows you very briefly some of the achievements that we've had. I'll not belabor anyone on this. but basically we have quantifiables that are enabling us to move this program from one level to another, and this cuts across all the areas. And so, these are just photographs of trainings in satellites that we undertake, and we are able to provide certificates when we go for trainings. We've supported labs for trainings, including colleagues from Tanzania. We also have managed to do facility assessments. We go to facilities in the counties, we assess them, and we can be able to determine the needs of the counties, and we are able to at least put in infrastructure that we think would be helpful. We've also, as I did mention, developed a registry, and this has enabled us at least to pull in data that we can be able to talk about. We also launch clinics and develop and sign MOUs with the counties that work with us. And more so, as I did mention, we do trainings in these regions. Besides that, we've developed a guideline that is now being referenced by different groups. And I hope this has been helpful as we work with licensing authorities to assist us to meet our requirements. Let me leave it at that, ladies and gentlemen. Thank you very much.
Thank you very much, Dr. Kibet. You have really given us quite a comprehensive presentation. It is of note that you have a lot of linkages to the other different partners, stakeholders, and even across the borders. We commend you for this great work. Although you have taken up a bit more time, we appreciate that presentation. So moving on, we wanted to get a presentation from Dr. Kibe Victor. He is the head of the NCD division at Nairobi City County. And he is a pharmacist by profession with a postgraduate in health economics, as well as pursuing infectious diseases. We welcome you, Dr. Kibe. Please adhere to the 15-minute barrier on time. Karibu.
Thank you very much, Dr. Mutiso, and to all our participants for this symposium. I'm humbled to be part of it, and I wish to make it as short as possible. On behalf of the Nairobi City County government, first of all, greetings from our new leadership. Honorable Sakaja is our new governor in the city, and I would like to take this opportunity to just take you through a brief overview of the journey and the milestones that we've covered in terms of sickle cell disease. Today, it's an important day for us as we discuss the various milestones that we've achieved as a county. Maybe next slide. Yeah, so Nairobi City County government, we've been in collaboration with various partners to see how we address the issue of sickle cell disease. And I can start by saying that we've conducted a study, began in January this year, on the status of the sickle cell disease management. Nairobi being one of the participants, and I thank the German doctors, the German government for this collaboration. We worked along with them in supporting one of our clinics at Madare North Health Center, which is a level 3 health facility which has been offering care and treatment for patients living with sickle cell disease. And I know this has been cascaded elsewhere. We'll be soon sharing the outcome of this study, and we'll invite again all of us to be part of it as we discuss the outcome of what we found about sickle cell disease. Next slide, please. Yeah, so in terms of screening, care and treatment, diagnostics, we've had health workers capacity building. This is work in progress with one of our partners, the Sickle Cell Children Foundation, have been supporting in this model, where we are looking at addressing issues around the same condition and also training community health volunteers to be able to identify the people suffering from these conditions, referring them for appropriate care treatment. We've managed to do trainings for the CHVs, and we also have a model where we are able, through the community health strategy, to strengthen the same at the community level. We were able to do some distribution of branded reflector jackets. So this is work in progress, and we appreciate the partner support. I must say that there's been a lot of support from various stakeholders, multi-sectorally, who have come in to support what we are doing. And I really appreciate, on behalf of the Nairobi City County government, the support that we've received from various stakeholders, as you see in the next slide. So we've been working closely with the Ministry of Health. They've supported us. They've scaled up support at one of our facilities, that is Kiberediyo Health Center. Dr. Gadesha, thank you very much, and your team, for coming on board. We have Laborex, which is a private company, digital liability company, which has come on board to help us with screening of the same for sickle cell diseases. We have Children with Sickle Cell Foundation, championed by one Selina Oloda, who has been very helpful, among others, including PATH International and Sickle Cell Foundation, as we'll be hearing from my very good friend Owino about what we are doing to try and come on board to synergize our collaborations towards the same, to see that people, or other patients with sickle cell diseases, or those who are culpable to the same, get the requisite prevention, treatment, care treatment provisions for the same are available. Nairobi, by the way, happens to be the hub of healthcare services in this country, where we host across all the other 47 counties, people coming from other counties and collaborating with us to help us achieve this foundation. Maybe we could move to the next slide. Next slide, please. Yeah, so in support of screening, care and treatments, diagnostics, et al., we have had a launch of HB electrophoresis and biochemistry equipment. This was a donation from the German government through BNZ at Baraka Medical Center, which is at the heart of Mathare North, an urban slum in the city, where we have also a support group that we've been engaging with and have cascaded and tried to bring up a similar model at Kiberediyo Health Center, which is one of our periphery health facilities, where we have been able to be screening, treating, taking care of those patients. And we really appreciate the support that has come a long way in supporting these facilities, the people living with these conditions, and we must appreciate, and I really say thank you to all the stakeholders, individually, multi-sectorally, multi-sectorally, who's come on board to support us, even in other facilities, as you'll see in my next slide, where we have tried to scale up healthcare workers training, as well as CHVs, to be able to carry out the message, not just for these conditions, but for many other non-communicable diseases. Next slide, please. So it goes without saying that we have challenges, and some of these comes to the most common being the erratic supply of essential medical supplies to support sickle cell diseases. Of course, our healthcare workers need to be continuously educated. We know we have a gap in healthcare workers' knowledge on how to manage this, much as they maybe have undergone this training during their primary healthcare training. This cuts across all cadres, the occupational therapy, all the way to specialists who have spoken to us, including Professor Jesse. And of course, with that comes the issue of referral. We are having a technical working group this coming Friday to try and address the issues of how we relate these clients for care across the various levels of healthcare, that is from the primary healthcare all the way to the tertiary and referring hospitals. But I must also mention that one of the biggest impediments, like Dr. Ganesha mentioned, has been lack of data and records to inform us for decision making. And I would urge the ministry as the policymaker to come up with tools and policies to guide how we then go on to document work that has been done, to document the disease burden, to document the various outcomes for people living with sickle cell diseases. And then, of course, as the theme for this symposium goes, the new pandemic being non-communicable diseases, the budgetary allocation for non-communicable diseases, and specifically so speaking to sickle cell diseases, has been dwindling. But however, as a county and as one of the key policymakers in this, we are trying our best to see that we increase our budgetary allocation for sickle cell disease. I know as it sits and stands with the Nairobi City Council government, we have a budgetary allocation of approximately 5 million Kenya shillings, which translates to $500 or thereabouts. But we are looking into see how we could escalate these through petition from the community. We as policymakers and decision makers to see that there's a lot of allocation for this. And I hope that in the next financial year, we are going to be able to be planning better, of course, informed by data, that we'll be able to speak on to how we improve not just the Nairobians, but the citizenry, or rather the accommodation of Nairobi as a county to be able to address the issue of sickle cell disease. Next slide, please. So I think without much ado, a lot has been discussed about the condition. We've had various panelists, and I thank you all. However, I would want to echo that we have representation from the various stakeholders when it comes to the Council of Governors, in consideration that health is an evolved function in this country. And we bring on board stakeholders, the curriculum development, and the various training institutions, that they support the development, the training of healthcare workers into this. I must say that there's a lot of confusion when it comes to over-the-counter prescriptions and people obtaining over-the-counter medications about these conditions. Please let's adhere to the national guidelines. I would urge all our stakeholders come on board and help us support us in, eliminating this process of where I have a pain, I don't know what to do, and then the outcomes are not so very good. So otherwise, thank you so very much. I'm very happy to be part of this. What I can say from where I see it is that we are scaling up provision of screening, diagnostics, and care and treatment for sickle cell disease in line with the universal health coverage for the same across the county. And in future, at Kangemi Health Center, Kibera DO, Madare North, Baraka Medical Health Center, among others, that we are going to have these services available and accessible at no cost to the Nairobians. Thank you so very much, and over to you, Dr. Muchiso.
Thank you so much, Dr. Kibe. I believe that is actually very encouraging news as concerns access. I know throughout the presentations, we've had challenges with a number of issues that cut across, but there's actually hope in your statements, and we are grateful because a lot of our participants on this forum also include persons with a lived experience, and we are grateful for that. Please take our greetings to the teams at Nairobi and give them our thanks. So with that, we'll call our last panelist. This is a sickle cell warrior who is an advocate. She is a person who lives with sickle cell disease, a board director of the Sickle Cell Federation in Kenya, and as well a regional coordinator for Africa Congress on Sickle Cell Disease. She's a Voices Fellow of the NCDI Poverty Network and the Executive Director and founder of the Sickle Cell Huru Trust. Please welcome Eunice Owino. We will give you 15 minutes. You have the floor.
Thank you so much, Dr. Stephen. And as you have heard, my name is Eunice Owino, and I'm a sickle cell advocate and a sickle cell warrior. The reason why my first slide, I just say from a sickle cell patient to a sickle cell warrior and an advocate. It's because the disease does not define me. As a patient, sickle cell does not define me. Next slide, please. So I'll look basically what I'm going to talk about. I'm going to introduce myself, which you've already done, and then I tell my story, and then the advocacy work, which I've done, and then the organization which I run, and then also collaborations which we have done so far. Next slide, please. So my name is Eunice Owino. As you've heard, I'm a person living with sickle cell disease and also a sickle cell advocate. I am a voice fellow with NCDI Poverty Voices, where I was chosen among the 4. So I'm from Nairobi, Kenya. And also I'm the founder and the executive director for Sickle Cell Huru Trust, which we call SCAT Kenya. I'm a board member of board of directors of Sickle Cell Federation of Kenya, which is the mother umbrella for all the organizations of sickle cell in Kenya. Then I was newly appointed as the co-secretary for the Hematological Technical Working Group. And also I represent Kenya in terms of, I'm a Kenya representative for Africa Congress on sickle cell disease. So any matter sickle cell, I am your person to go to. Next slide, please. Yeah, so my story is Eunice was born in Nairobi, Kenya. I was born actually at Kenyatta National Hospital. I was diagnosed at Kenyatta National Hospital at the age of 8 months. And I grew up spending a lot of my time in and out of Kenyatta National Hospital. I'm really emphasizing Kenyatta National Hospital because this webinar and seminar is also, it's about also Kenyatta National Hospital. So Kenyatta National Hospital was like my second home because as you live with sickle cell as a young child, you spend a lot of time in hospital because you do not understand what's going on. You get painful crises all the time. You are always sick all the time. So Kenyatta National Hospital used to be my second home. Next slide, please. So basically at the age of 9 is when I can say I began to understand what sickle cell was about, and why when I was younger, before 9, my parents kept on telling me you need to be drinking plenty of water, I need to eat vegetables, I need to take my medications on time, I need to keep warm, and I used to go for checkups every 3 months or even less than 3 months, because growing up was a bit hard because of weather patterns changing, and also just cold season, warm season, getting too excited. Those are my triggers when I was younger. I used to get a lot of crises when I go through those triggers. And actually when I reached 9 is when I understood why my mom kept on telling me, you need to wear your sweater, you need to keep drinking your water. And actually, next slide, please. I can say when in last crisis I had, a very major crisis, was in 2007, when that was the last time I was hospitalized because of having a major sickle cell crisis. And then also from 2003 to 2013, I used to suffer from a vascular neuropathy, which means that I had an hip pain that started in 2003, but no doctor could tell me exactly what I'm suffering from. So in 2012 is when I met a physician in Aga Khan Hospital, and he's the one who told me exactly what I was suffering from. And he told me this is called vascular neuropathy, in short AVN. And from there, I was able to do a total hip replacement now in 2014. And just understanding what this is and why you need to go through it, and also just coming out and becoming better. Because with the AVN, I used to collapse all the time when I wake up. I used to just have pains, and I used to be on so much painkillers that my body never used to function so well, because I was always taking a lot of painkillers just to try and ease and make the pain to be as part of me and normal as me. But once I did the total hip replacement, I stopped taking medication, and I now just started now managing myself again. And now it's when I went directly now into trying to understand the kind of foods I can eat to help me manage even the leg ulcers, because I also have leg ulcers. So just eating different foods on how to manage leg ulcers, different foods to help me generate my HB levels to always be up there. And then also just going back to the basics of sickle cell, of how do you manage sickle cell. And from that, for me, that I can say has helped me in a place where I've not been really hospitalized for a very long time, apart from 2007, where I was hospitalized for 1 week, and it was just an infection and a crisis that kept on coming in and out. But after that, and now I just took a deliberate purpose of just watching what I'm eating, checking how much fluids of hydration, how am I hydrating myself as a person. So after the hip replacement in 2014 is when I decided to join LEA. I know majority of you know LEA, and that's how I started doing advocacy. So that's where my advocacy journey started. But I'm one person who love life, and next slide, please, just shows what I do my things as a normal person. Sickle cell does not limit me. Fun facts about me: I love music. I play instruments. I love supporting sports. Yes, that's Gor Mahia. We had gone to support Gor Mahia. And I love dancing. So those are the fun facts about me. And my hobbies are, you can go to the next slide. My hobbies are photography, videography, camping, traveling. Those are things I love to do as a person. So it doesn't mean that because I have sickle cell and the doctor will come and tell me, you know, sickle cell patients should not fly in an aeroplane because the oxygen levels will be low. That's a lie. I've traveled enough times. I've gone to different places. Thank God for that. I love camping, so weather doesn't disturb me because I know how to manage myself. I love taking photos, and I love doing videography. So next slide, please. So this is one of our advocacy work where we collaborated with John Chazima, and I call them my sickle cell family. Reason being, because of also having too many support groups. Sometimes it's just good to call people and just have a fun day where we have all the children, all the parents, and we just play these fun games that we used to play growing up. So the kids can also enjoy and see that, yeah, my parents can also play. And they can't limit me and say, because I have sickle cell, I can't play. So sometimes as part of our support groups, we also do fun days. So this was one of our fun days in, what is that park opposite Uhuru Park? There's a park, it's City Park, yeah. So we were just sitting there having fun and enjoying ourselves. So this is my sickle cell family. Next slide, please. So this is part of my advocacy work, which I've done also in collaboration with other people. The first picture you can see, that was the first time we launched the East Africa Sickle Cell Alliance with all our East Africa groups which are advocating for sickle cell. You might know a few of the people. Then the lower one is where we were signing the Global Charter for NCD. Then the upper one, I was teaching in a support group in Eldoret, just talking to the parents, talking to the patients, how also to manage themselves. And then the lower picture, we were doing the advocacy for just creating awareness in Nakuru during World Blood Donor Day some years back. Yeah, so next slide, please. So basically, the organization Sickle Cell Uhuru Trust is a non-governmental organization where it was founded by people living with sickle cell and also run with people living with sickle cell and caregivers, medics, and also people working in the sickle cell space. And also our aim is basically to empower especially the adult warriors who have really been neglected in the society. Our aim is to make sure that they grow up, they go to school. After they finish school, what do they love doing? Whatever they love doing, we get them a mentor who works with them, and the mentor also helps them identify and get scholarship to go to the next level of education. So sickle cell does not limit anyone. People just limit themselves. So the next slide, please. So some of the collaborations we've had as a Sickle Cell Uhuru Trust or SCAT Kenya is with Ministry of Health, when we ran the Kibera Clinic in collaboration also with NCDI Poverty Network during COVID. So we were able to get and support over 360 plus patients who are in Kibera. And then also we've also done presentation through the Ministry of Health, and also personally I've spoken, and I became the part of Africa Congress on Sickle Cell Disease. I'm part of the NCDI Poverty Voice Fellows. I also have collaborated with John Chazima and also done a lot of stuff with Sickle Cell Federation of Kenya, and also beginning of on the 6th and 7th of this month, we were in Homa Bay, where as part of my the fellowship, I was sensitizing and giving out actually the clinical guidelines to the medics and medical practitioners in Homa Bay. And at the end of it all, you could see that the way even just when Dr. Gladwell was talking about the guidelines and not being able to disseminate it to the lower people who really need it also, just to go back and read and also refresh their mind. So these clinical guidelines are also critical that all the medics need to get it in this country, because we know very well that health is devolved, and if we can have these sensitizations and trainings being done in each and every county, and also just giving the clinical guidelines, it is also a good plus for everyone. Next slide, please. So Martin Luther said that if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. but whatever you do, you have to keep moving. So for me, this is saying, personally, I take it because with sickle cell, 1 minute, you're very well, you're happy, you're excited, you're doing so many things. Then the next minute, you can't do anything, you're being rushed as an emergency. Then also, when you're rushed as an emergency, then if our medical care cannot even just give you the basics, like when you're having a crisis, what do they need to do? Do they need to put you on opioids? Do they need to put you on mild painkillers, or do they just need to put you there to stay and wait until they are done with serious cases? Because sickle cell pain does not show. It is a pain that is in the bones, in the veins, inside that, where you cannot see it. But when a patient says they are in a serious pain, please heed to that as a medical personnel, as a student, as an upcoming medics, please heed to that, because our pains, when they're not cared for immediately, can really cause a lot of organ damages, where we end up having stroke or even brain damage, or just being paralyzed because of all this. So be it when a patient tells you they are in serious pain, and what else can you give them? What are they allergic to? What are they using? What works for them? And after the pain, then now you can come and start doing a research on why are they having pain? Do they have infection? Is their HB low? Are they also going through what exactly is causing the pain? So those are the things that you need to check. Next slide, please. Thank you very much. Any questions, I'll be able to answer. Thank you so much, Dr. Stephen.
Thank you very much, Eunice, for that wonderful presentation. You are indeed an inspiration to us and to others, and we appreciate your work in advocacy. I think for most of the themes that have been covered in the presentations today, you have actually circled through all those different spheres, and we are quite grateful for having you on this forum, for taking the time. Maybe for the next 2 or 3 minutes, I will let the panelists maybe respond to any questions that might be on the chat before I hand over back to Dr. Ojuka. Or any issues that may be pertinent, we can give our panelists a minute each just to say something in closing.
Steve, you can also review the questions in the Q&A panel.
Yes, there have been quite a number of questions in the panel. They have been quite insightful. I think some of them still remain unanswered. So someone who is using a techno is asking if a child can have sickle cell disease if both parents are not positive for the same or carriers. I don't know who would want to take that up from our panel. Another question that is coming up is how affordable is the sickle cell scan and the other tests? Maybe our more technical panelists can take us through that.
So Steve,
Yes,
I'll take that. I can take the question for the techno person. For somebody to have sickle cell, you need to get the genes for both your parents. So your parents both have to be carriers for you to get sickle cell.
Thank you very much. How about the issue of cost?
For screening, depending on where you screen, and right now I can say the cheapest place you can screen in the country is Eldoret, because they charge $720. Baraka Center, they charge $2,500, and you'll get a full hemoglobin test screening done.
Okay, thank you very much.
I'm not sure about the cost of the rapid tests. I think they're a bit cheaper than the HP electrophoresis. Dr.
Yes,
Kibet, do you know the cost of those? Yes.
Yeah, thank you. So as we were developing the policy on infant screening, cost is one of the issues we we looked at, and we're trying to lay down the costs of that sickle cell screening. And what we found is that the lowest, actually the rapid test would range from 200 to 1,000. So the screening tests are a bit more cheaper. And when now it comes to diagnosis, now that varies from place to place, and I may not have the actual figures for the diagnosis. But I think I also want to point in that the good thing is a lot of these tests, both screening and diagnostic, are now catered for by NHIF with their recent expansion of the packages. So even as we go out there and maybe treat our patients, it's good to encourage them to also enroll with NHIF. Yeah, thank you.
Thank you, Dr. Gladwell. Maybe before you go, there's just a question from Brian Sigu. He asks if the national rollout of policy on infant screening for sickle cell disease is going to be countrywide or only restricted to a few sickle cell endemic regions.
Okay, thank you. I thought I replied to that, but no, in view of the geographical distribution and also the resource required, we are going to do it at a phase approach. And the first phase will actually be a project covering 1 year with a few counties totaling up to 4. And then for the next 5 years, then we'll take the other high burden areas. Then after we've taken care of the high burden areas, that is after 6 years, that's when we'll have national rollout, in view that there's also intermarriages that are happening. And even though the cases are quite scattered, there is indeed a role for screening in the other counties that have not been considered high burden for sickle cell. Thank you.
Okay, thank you very much. Maybe a final.
Prof. Nzala has his hand up.
Oh, yes. Please go ahead, Dr. Nzala.
Yeah, thank you, colleagues, and thank you for organizing this very, very timely symposium on non-communicable conditions in Kenya. Is actually true to what Ojuka said. It's an emerging problem that we must get involved into. Now, just two things. Since this is a research week, I would like to hear from Kibet and Gladwell and Jesse. What are the research questions that you guys are involved in these hematological conditions? What are some of the research projects that you guys are involved in? And also to add that, Jesse, when you presented about the challenges and you talked about special tests, all those things are available here. We are getting samples from Rwanda. We are getting samples from South Sudan. And I wonder why we are not getting samples from this country, because flow cytometry and all these other tests we talked about are our bread and butter here at CAVI because of the kind of immunology we do. So I think we should look at what we have and utilize it regardless of where it is. But then the next thing is the issue of mapping. Other than sickle cell, whose geography is somewhat well known, but expanding, as Gladwell has said, have we mapped or are we planning to start mapping these other hematological conditions just to be able to understand the emerging issues? Over to you guys, and anybody or all of you can respond. Over.
Okay. I'll start off with what I can from those. Thank you very much, Prof. Fomu, for those questions. Regarding the specialized tests, the flow cytometry, the molecular, I'm sure, Prof. Fomu, if somebody came with a list of those tests, how much would it cost? Our issue is especially the access of anybody anywhere in Kenya getting that. So if somebody was in, say, Taita Taveta, or was in Malindi, or in Northeastern, first the sample has to be taken, then it has to be shipped, then it has to be done. And many of these, like flow, need a sample that is viable. So you have to involve, and often, sometimes even when we are sending tests by couriers, it gets stuck somewhere in a hot place. Then we are told the specimen was not viable. So those are considerations. And in the public sector, most of our patients are actually in the rural areas. They cannot afford those thousands. So the tests, yes, they may be available, but only to those who can afford. And maybe that's why they're coming from out of the country, you know, because some of those ones who are sending can afford it, but maybe you will advise us. But it's good to know. And I think Prof. Omu's center at Kavi have a lot of testing capacity. And I think there's need for this to be known widely out of University of Nairobi, and even in the referral, the sample referral network that the ministry has, so that people know what options they have. Then the mapping of the diseases, that is an excellent question or comment. Indeed, if I talk on the side of cancers, there is now efforts to have a population-based cancer registry, which will show where these cancers are occurring, what types of cancers they are, and you know, the age and the patient demographics, etc. However, the entry point is accurate diagnosis. So without getting accurate diagnosis, even the mapping that we're doing may not be as good as it should be. And in terms of questions to answer, Dr. Kibet, myself, and most of the other panelists are involved in several research activities. Some of the current ones that I might be involved in is like looking at access of treatment or access to cancer treatment for children. And that's a multinational study that we're doing, even with patients, with collaborators in Tanzania, Uganda, and West Africa, just to see how do children with cancer access their medications. What can we learn across the borders? How can we form collaborative groups for this? I'm also involved in several clinical trials, multinational clinical trials in sickle cell disease, where we're looking at some of the newer treatments. And there is hope, because even though many of these newer treatments, when they are registered by FDA, they're very expensive, there are programs to make them accessible in the countries for those who participated in the trial, to make those products available for the patients free of charge as well, until they're accessible in their own countries.
Yeah, just to respond a bit, you could allow me a bit of latitude here. The reason I'm interested in some of the research work that is going on, we are interested in looking at the interaction between non-communicable and communicable conditions. Because some of these individuals come down with infections, and how do these infections behave under certain conditions when you have individuals with chronic problems. So there is an interest there. And we are beginning to see interesting aspects. For example, I listened a bit, but I didn't get to go there. Just to give you an example, there is an interest now to look at the interaction of TB and diabetes. All right? What is going on there? And there's very interesting work that is being done. So my interest is also to look at those kind of things. And in terms of sample collection, let's not fear, it can be done. If we can get a sample from Rwanda, we can certainly get a sample from what is the farthest corner? From Mandela. All right, we can be able to do that. But maybe let me also hear from Chikuku. Chikuku, what are you doing?
Prof, this is Dr. Kibet. You asked a question on what we are doing in terms of the interactions between non-communicable and communicable for hemophiliacs, or?
Yes, yeah, that is correct. Generally, what kind of research are you involved?
Hello, Prof, I'm losing you a bit. You're not
Sorry,
so clear.
my interest really is what research are you involved in? Because part of this is to also join in and build collaboration.
Mutiso, did you hear Prof properly? I picked some aspects and lost quite a bit. Mutiso?
It was a little bit unclear, but
Yeah.
Prof is asking about current research projects with the interest of how we can collaborate if you wanted to join you with maybe someone else or some other stakeholders, something towards that direction.
Yeah, so I think just to answer Prof, we are actually trying to look at, you know, these complications that are associated with some of these disorders that lead to antibody production. And we know that infections are, you know, clustered under what we call danger signals. And so we would like to try and start seeing the relationships between certain infections and development of inhibitors in our patients. And so that level of interaction, I think, would be key. And actually, this might also help us to look at the various cytokines associated with the different exposures and what this means. So yes, I want to agree with the Prof that these are possibilities. And I think there's a lot more that is also happening within the dental world, trying to look at dental complications, some infection related with bleeding disorders. So yes, there is some very serious level of interaction between the two. And I think the best we could do is to try and partner together and do some of these studies to see exactly what happens within our population. I don't know if that helps, Prof.
I hope you can hear me. I don't know what's wrong with my mic, but that is clear. So let us pursue that and see what we can do, because part of that is what will form human resource for the next generation in terms of training people at the highest level to be able to manage these very, very, very complex diseases. Over to you, Chair.
Thank you very much, Prof, for those inputs. I can see Dr. Omedo is very active in the chat section. I don't know if someone wants to take up one or two of the comments. One of the things that she has mentioned is that, and this is in response to Professor Anzala, we can partner with the county laboratories. And she has also mentioned that sickle cell screening should be available to all the counties. There's diagnosis of many patients from communities that are not considered to be sickle cell endemic. And another comment she's brought up, I think that is quite pertinent, is that we also need to discuss stem cell transplant for sickle cell and other hematological diseases and consider cord blood banking. I don't know if there are some comments on that, maybe Dr. Kibet or Professor Jesse Gidanga.
Okay, allow me also to tie in some of our comments with
yes,
what
Dr. Garecha.
Professor Omo had said. Yes, the conversation of integration with the communicable diseases is very much alive, especially in the areas of, like, for example, the hypertension and HIV, also TB and diabetes. We already have bi-directional screening guidelines. The area where I think we have been a bit slow is for hematological conditions and communicable diseases. But I think this webinar has proven to be a wake-up call that we need to strengthen our efforts there. And indeed, our hematological diseases, TWG, has one of the mandates is to come up with a research agenda. And I think that will form the core of that function. When it comes to mapping, there is a need for recent data. And more so, we want to start with the more common ones and maybe the more where at least there are resources and goodwill placed. That is for sickle cell and hemophilia. I understand the last mapping was some years back, especially for sickle cell, for Professor Lodge. And then after we map, I think we'll be in a better position, Dr. Deborah, to actually make a case of country rollout of the screening, or we go phased approach. Right now, I think we're considering the economic of the resources point of view, and that's why we limited ourselves. And in view of the much advocacy we still have to make, and the inroads we still have to make for the counties. Yeah, thank you, and over.
I can also ask Dr. Nzala to comment, because I know they're doing cord banking at Kavi. So I think Dr. Mino is quite interested in that. As for transplant,
yes, we have capacity, because we've been working with plastic surgeons. When they want stem cells, they actually bring adipose tissue, they do liposuction and bring the sample here at Kavi, and we isolate our stem cells and give it them back so that we concentrate the stem cells for the purposes of transplants. It's very good in management of wounds and these other things. And we have also been having a program on mothers at delivery, because you know the placenta is a critical tissue with a lot of information. So what we have also been doing is to collect the placenta at birth and look at cord blood. And we have stored about 5 or 6 samples so far. But really, as a country, and maybe through discussion with the NHIF or other partners, I totally believe we can start a stem cell transplant here for sickle cell disease. I have been to centers in City of Hope some time back, and it's not difficult. And we should get away from the term low income resource setting. We are not poor. We are totally not poor. These things can be done. The technology is available. Human resource is actually there. So let some things emanate from this meeting, Ojuka. And it should not just be talk as usual. Let 1 or 2 things emanate from here that we can initiate across the country. Over.
Thank you, Prof. I think Professor Gidanga had something to say on transplants.
Yes, in fact, I was going to say that Dr. Kibet should talk about transplants, since he's been involved in one of the centers that has done its first transplant in Kenya. Dr. Kibet.
Yeah, so thank you, Prof. What I could possibly just mention is that I would actually love that we started sequencing, patients that develop inhibitors, so that we can see what mutations are actually involved. Because we've seen patients from certain regions developing antibodies very easily when exposed to medications that we use for treatment. And I think Prof. Nzala and the team, we could start thinking about some of the mutations that could be causing this kind of outcomes. But having said that, for sickle cell and other disorders that may benefit from bone marrow transplants, I think as a country now we have capacity to do this. One of the things actually we are working towards is to have our first sickler being prepared for a possible transplantation next month. And we are working very closely with colleagues, including Prof. Nzala and the team at Kavi. And I want to agree that as a country, we actually have capacity. I think what has been lacking is that level of coordination that we all can benefit from, just in case we were to work together. But overall, I think sickle cell is likely to benefit, and other diseases that we have in country. And I think the costing element is something that can be discussed as we move along. But the costs are likely to come down, and this should be much more affordable to our clients. Over to you, Chair.
Thank you very much for those sentiments. Maybe we can take 1 or 2 more issues to address. I think Martin Nafuko has joined us from UMIAS and is asking, what are the plans that target rehabilitation, both in the crisis situation and occupational management? For example, the employers being sensitized on missed work hours due to many hospital visits. And the other question I can see was still raised by Dr. Omedo, and she has made a comment on malaria control in stemming the AS mutation of red blood cells. Maybe we can address those two. This would probably go to someone who's been in the clinical spectrum.
I'll just talk about the malaria AS, malaria control and stemming AS. So the majority, I mean, the history of sickle cell is that it started in a malarial zone, and the mutation of S and the AS now conferred that that immunity to severe malaria, prevented them from getting the some protection against severe forms of malaria. However, now as we are, most of the individuals who get sickle cell, actually it's inherited from their parents. And the main way that one might be able to is especially enhance prenatal counseling to individuals, knowing one's status, whether they are carriers or not, and giving them prenatal counseling, and even at the level of premarital, people can test to know their status, so that they are made aware that they may have children who have sickle cell. So that awareness is what might be able to help reduce the numbers of sickle cell now, and as a way of controlling new patients being born with a sickle cell disease. That's what I would comment on that. There are places where they actually even do prenatal testing of the fetuses, etc., but I wouldn't go into that right now. But
yeah, also just to add and talk about employment and sensitization on and also frequent admissions. So that's why I say, as a patient, you need to understand your body. You need to know what are your triggers, what make you get a sickle cell crisis. So when you do that, and also when you get employed, also you need to be honest with your boss, because some employees will accept, some will not. So, and also just understand what is your right as a person who is employed. What is your right? How many off days are you allowed to have? How many sick off days are you also allowed to take? So these are the things you need to consider. Personally, I did not know that. So by the time I was being told with the doctor to either quit my job and take care of myself, so I began, because he was telling me I'm not healing the way I'm supposed to heal. And the reason why I was not healing the way I was supposed to heal is because I was under a lot of pressure at the workplace. So I just had to go back, personal evaluation, and see what is really going on. It's when I came to realize that I'm having a lot of pressure at the workplace, and it's making me not to heal the way I was supposed to heal and go back to my normal self. So I had to quit the job without really going through the procedure. But later on, when I met a lawyer, they were saying, no, you shouldn't have done that. There are laws that are protecting you. You're not even supposed to be fired. There are laws that protect you as a person who is living with any non-communicable diseases, whether sickle cell, whether diabetes, because there are days you're supposed to have as off days, there are days you're supposed to take as sick off. And also you need also to just have a sitting with your boss, because as a person who is, because with sickle cell, I've seen when I am sick, I can't do anything. When I'm well, I work actually extra hard. So I end up doing more work than the time I lost when I was sick. So you also need to show your employer that you add more value to the company than when you're sick. So they need to also understand you, and you need to have that balance and commitment, where they also commit in terms of giving you your space, and also you commit, and also try and avoid what triggers your crisis, so that you stay longer at workplace instead of getting sick more. Back to you.
Yeah, thank you very much, Eunice, for that very nice rejoinder to the question. As regards workplace and workplace-related difficulties for patients. I was still going through some of the comments. I don't know if there was one I thought was quite interesting, was brought up a little bit earlier, although I can see it was answered. Yes, this actually is coming from Lynette Obero, and she asks whether gene therapy can cure the sickle cell condition. For Saitoti George, we can get the guidelines of the Ministry of Health website. To the panelists, can gene therapy?
Yes, it can. And in fact, there have been published reports of gene therapy successfully curing sickle cell. However, before you can roll out something like that, you have to have more clinical trials. And then, of course, it is very expensive. So, so far, it is still very expensive, and therefore it still is not widely available. But if using gene therapy, one would be able to cure sickle cell disease.
Thank you very much.
Mutiso?
Yes, you have the floor, Dr.
We
Tobet.
actually are planning to start gene therapy for hemophilia and other bleeding disorders. So gene therapy, I think, is going to be a conversation soon. So as we keep progressing as a country, some of these, modes of therapy may be coming on board. And as Prof mentioned, we still have to do trials, though. But one thing I know is, as a program, we're actually planning to start gene therapy for hemophilia and other bleeding disorders.
Yeah, and then just to add, really the discussion that is going on now, and maybe is also the discussion that we must have, is what now they are referring to as individualized medicine. So that every patient will be looked at individually, so that even gene therapy could be amenable for certain genes and not all of them. And that's why, Shikuku, when you are talking about sequencing and looking at all these things become important, because when we begin to map and when we begin to sequence, then we begin to understand the differences. So as we discuss this, maybe the next symposium should be on individualized medicine and what does it mean for the future in this country. Over.
Thank you very much, Prof, and all the people who've contributed to that very comprehensive answer. I saw a comment from Dr. Omedo yet again concerning, also seeming to be on the technical end of things, concerning EBV vaccines. This should be Epstein-Barr. I don't know if someone from our panel can take up on that.
What we know about the bucket lymphoma and Epstein-Barr virus is that there is an association. However, it is not like 100%, because we do know Epstein-Barr virus is so ubiquitous that in our population now, I think the majority of us would have that, the virus, would have suffered the viral infection, but we don't have bucket lymphoma. So even looking at bucket lymphoma itself, it's mainly the endemic subtype, which has EBV, very nuclear proteins that are also incorporated. But in the sporadic subtype, that's usually the one where they have a lot of abdominal disease and bone marrow disease, we don't find that association very much. And what we have noted now is that even the pattern of bucket lymphoma seems to be evolving. We used to see the majority of our patients with jaw tumors, but now I know even in Kisumu, where in Western Kenya, where they used to see a lot of bucket lymphoma, and in Coast, they're seeing a lot of abdominal tumor, widespread tumor from the onset coming up. So there's a lot of questions that are coming up, and looking at the vaccine to such a ubiquitous virus to try and prevent bucket lymphoma, which there's an association in terms of cost effectiveness, would be very interesting to look at with that. But I replied to Dr. Deborah and I said, it is a very interesting research question and definitely one that we should undertake, even if it's, to see and to try and get more information of that very critical role between EBV, bucket lymphoma, and the associations, etc.
Thank you very much for that response.
Dr. Anzala, being a virologist, he might want to add something onto that.
Yeah, it's interesting because I think part of what we should pick from here is that herpes viruses, EBV being, being one of them, is that once you are infected with these viruses, you are infected for life. They have that propensity to hide in certain cells and hide there, for life. So as we discuss, and indeed vaccines are being looked for, the issue will be at what stage do we vaccinate? But nonetheless, as Jesse has said, there are a lot of variants of these viruses, and these variants must be totally understood. So that is actually going on. But
Grandma's recipe that
just understand from that point of view that it might not be your standard vaccine, but it also might also be a vaccine that we might individualize, in the sense that we look at it from a case-to-case basis rather than a vaccine that you'll say you actually go and give to the general population. But the space is open and there's a lot of discussion. But interesting enough, just to mention, we did work with one of the PhD students in surgery, ENT, and we were looking at tissue from tumors of the head and neck and just trying to look at what viruses were present in the tissue. And interesting enough, there was EBV was there, HPV was there, CMV was also there. So you begin now to really wonder what is the interaction. So it's an interesting aspect, but then that's what research is all about. Over.
Thank you very much for those very interesting observations. I think we've come to the end of our time up to this point, and we have had quite an interactive session. I think I want to say thank you very much to all our panelists and everyone who has contributed. We are grateful to the University of Nairobi and the Kenyatta National Hospital for having this symposium. The symposium goes on all week, and the theme is on NCDs, the new pandemic. And I'd really like to summarize and just go over the areas. I think Dr. Gladwell really highlighted the issues of policy. And I felt that that message was clearly carried. And as Professor Gidanga took us through issues with diagnostics, I think the message here, the clarion call, is that we are still able to carry out quite a good diagnostic experience in the space of hematological conditions. Dr. Shikuku, I believe, has covered hemophilia, and that actually was quite a brilliant presentation in terms of how the different stakeholders and partners link all the way to Tanzania and how we have shared experiences. And also from Dr. Kibe, the NCD head in Nairobi, he has shared his experiences with the work that's being done here. And we can see there's already expansion even into some of the facilities he mentioned, Kibera Dio and Kangemi and the others. Finally, I think our lived experience with UNIS is actually testament that if we hold hands, we should be able to achieve the goals we are looking for. I thank everyone for joining us once again. So unless there's a word or two from our lead on this particular session, Dr. Ojuka, maybe you close for us. Thank you.
Thank you, Steve, for that good moderation. I thank everyone for the participation, for coming, for asking questions, for giving suggestions, the panelists for your contribution into this space. I think there are a lot more things that we can do to better the health of our population and in our country. And as you hear, there are many challenges, but as Professor Muansala and Professor Jesse Githanga and the panelists said, there are things that we can do as healthcare workers, as individuals, even if you are not a healthcare worker, that can improve our health as a country. And so I would want to thank each and every one of you for coming. We continue with these symposiums. Tomorrow we will be looking at cardiovascular diseases and hypertension, how are they, how the magnitude in our country and the challenges and what we can do at an individual level as patients and as healthcare workers to also improve our healthcare. So I want to thank you and see you tomorrow. Have a good evening.
Thank you and good evening.
Bye.
Bye-bye. Thank you very much, everybody.